effects. We said they're stimulant, mechanism of action, they inhibit the norepinephrine uptake, puts the body in a more sympathomimetic mode, right? We become more alert, more active, okay? Now, other molecules which have been modified chemically don't have this, see? There's no other effects. If we look at the lignocaine, if we compare it to the bupivacaine, for example, one has a fast onset, okay? But see, bupivacaine has a slow onset and a long duration. So if I want something with a longer duration, I might use bupivacaine and something else, and I'll show it to you later. So let's talk about lignocaine. Lignocaine is the most widely used local anesthetic, effective by all routes. Faster onset, as we said, can be available as injections, topical solutions, jelly, ointments, and also it can relieve itching and pain. Type. Let's discuss adverse effects. Anesthetics, cardiovascular, respiratory, okay, and that's why and also for the kidney and liver, okay? So for the central nervous system, dizziness, lightheadedness, confusion, sometimes they get twitching, convulsions. So, but cocaine is a special case. Again, euphoria, alertness, reduced fatigue, okay? But then after it wanes off, severe CNS depression. طب cardiovascular دائما local anesthetics, even the general anesthetics, they have this hypotension thing, okay? Can you, you've taken cardiovascular block? No. Yes? Okay, so what do we, can we remember something that we've seen here in the cardiovascular block? Antiarrhythmic drugs, one of them? The drugs is next year. Okay. So let's say that cardiovascular adverse effects with local anesthetics is depression of myocardial contract, severe hypotension. Okay, so we want to make sure here that we are giving vasopressin, something to counterpart that effect. Okay, phenylephrine during the surgery or during this effect, we have to make sure. It depends if you're giving high dose, and we see this in the general anesthesia, but it depends, dose dependent, that this might be experience severe hypotension, cardiovascular collapse. Okay, in the cocaine, no, it's different. Again, we have heart rate, vasoconstriction, hypertension. It's a sympathomimetic, heightened sympathomimetic type. Here we go. So we said previously, I said when I compare ester local anesthetic with amides, the esters has been shown to have more allergic reactions and cross reaction. Yani, if one is, you're allergic to one, don't take the whole group of esters. Okay, why? Because once it is metabolized, it produces something called para-aminobenzoic acid. And this is common structure through all the ester local anesthetics, correct? And this is thought to be responsible for all the allergic reactions seen with this group of local anesthetics. So this is take-home message. So here we go. It's antigenic. It's thought to be antigenic, and the body reacts to it in an allergic manner. And the amides extremely rare. Okay. This, I think, finishes the first part of local anesthetics. Summary: loss of sensation and pain may include loss of motor function. Drugs are usually injected directly at the site of anesthesia or topically. If you want a short duration, maybe you'll choose a lidocaine. If you want a long action, you might use bupivacaine. Okay? My lovely slide. Have you gone to a dentist recently? No? ما حدا عن انت؟ You went to the dentist? ما حدا عم بيروح على الدنتست؟ شو القصة؟ تشيك اب طيب، ما في كافيتي، كله مظبط اموركم، كله فلوسنج وجاردنج، كله شغال؟ ها؟ No? Okay. So the local anesthetics have the ability to vasodilate as well. The vasodilation that's going on, right? which means if local, I'm نحكي local. فإذا I'm giving an injection, let's say I have a tooth decay and I go to the doctor, I don't want to feel the pain, the doctor will inject a local anesthetic here. But in order for him to keep that going for a longer time throughout whatever extraction of tooth or whatever, he wants elongated. So what do? We know that the local anesthetic is a vasodilator, can vasodilate, which means that amount of medicine will dissipate from the site of activity, will go away. So what do? We give why? To do vasoconstriction. Okay, now we know. So what does it do? If I give a vasoconstriction, if I give typical example, dentist, they use it at all times. You think you're taking only a local anesthetic? Think again. You're taking something else. He's cheating you. He's giving you epinephrine. Why? Yeah. Epinephrine with a local anesthetic. I just said that. Two, because I wanted to stay longer, the site of action, okay? To slow systemic absorption again. يعني كمان the other thing, I don't want the effect of local anesthetic systemically. I want to avoid hypertension. Right? I want to avoid it ولا لا? I want to avoid toxicity on the liver and kidneys as much as I can. So I want to prolong the local anesthetic. I want to decrease local bleeding كمان because there's this vasoconstriction. Okay? So these effects decrease the side effects and increase the duration. خلصنا local anesthetic. Are you alive? Numb? Are you numb by now?
Doctor?
No? Yes?
I have a question. You said the local anesthetic dissipates from there?
Dissipate from the site. يعني انت اعطيتي injection هون. Amount of drug is here. Can move out of the site to go to the system, become in our system, which tally the pain will go, the pain will resume.
And it vasodilates the blood vessel?
Yes, that's the nature of the. So if it vasodilates and it dissipates, يعني زي diffuses into other areas, and I need the pain here, and I need to work here.
Yeah,
So
you're gonna feel more pain.
Huh?
You're gonna feel more pain.
Thank you. So what do? I give epinephrine, which
It prolongs it.
yeah, sort of it keeps you in one area, keeps the drug in that local area longer.
Do you have to know the mechanism?
أيها حكينا vasoconstriction. Vasoconstriction, keeping it local. Okay? يلا. General anesthesia. I hate general anesthesia. Let's not take it. I'm not a big fan of general anesthesia. Okay, so there's a big history behind anesthesia, how they, I mean, doctors throughout history, they used to make surgery the last resort because of the amount of pain it holds, because of the anxiety, because of, so they were trying so many things. Cocaine was one of them. Freud, you know Freud? Sigmund Freud. I think he tried it for his patients and he tried it himself. He became addicted in La La Land. Okay, so this whole thing here, this is William Morton's demonstration in October 17, 1846, which is the first public demonstration of the use of ether in anesthesia and in the States. Okay, so this is, they started with so many drugs, modified structurally, and it's a new era after discovering general anesthesia. Okay, so again, we're talking about irreversible state of central nervous system depression, loss of response and perception of stimuli. Here we're talking about complete loss of response. We are inducing in this case a state of unconsciousness. There's no pain sensation over the entire body. Okay, هلا, this is what we need from a general anesthesia. Are we gonna make it available through one drug? Unfortunately, no. We need the combo. So what do we need? It should provide 5 important benefits. General anesthesia, so please don't think of it as one drug. We don't give one drug in general anesthesia. We give a combination of drugs. Drugs that will sedate and reduce anxiety. Drugs that will lead to the amnesia. Skeletal muscle relaxation, we need it, right? We need it also for the intubation. Now we know why we need intubation. Suppression of undesirable reflexes and analgesia, okay? So there's unfortunately no single agent that provides all these desirable combination of drugs. Let's see them. No. عاوز تروحي? You're leaving? What do you want?
What do you mean by the second one?
The experience of definitely not. You want amnesia. You want loss of memory for that experience. So there are certain drugs that will do that. Okay. طيب هلا we call them pre-anesthetic medications. هلا حتشوفوا I think they can be both. I'm fine with it. Okay. So there are a list of pre-anesthetic medications. And there is, احنا قلنا general anesthesia, we said structurally they're diverse, but we divided them into the dosage form, يعني route of administration, either inhalational or intravenous. Usually intravenous is to induce anesthesia. And then the halogenated or the inhalational هذا is to maintain. And sometimes they would add on it some intravenous drugs along the way. Okay, so neuromuscular blockers, yes, we need it because we need facilitation of intubation and relaxation. Okay, we're doing intubation. We need it. So we need a muscle relaxant, neuromuscular blocker. كبيش? This is it's a recipe. I'm بعطيكم recipe. We're gonna cook together. General anesthesia. Okay, so let's الانترافينوس البروبوفول هون okay, is the one that now it's thought that it does the induction of general anesthesia. It's short-acting propofol, intravenous. Before it was, what was it? I can't remember. But they modified it, less adverse effects, so propofol is the one. Okay, opioids is given as well for pain. You will see opioids here and here. Again, it's okay. Okay, let's discuss initially. We're going to talk about the inhaled and the intravenous. Neuromuscular خلاص, we know why. Facilitation or intubation and relaxation. عشان we want to insert a tube. We want these muscles to be relaxed, so we give neuromuscular block. Okay. Type. Why do you think we need all these drugs of pre-anesthetic medications? Let's think together. Hey, table in front of us. Let's do it. Huh?
Less pain.
Less pain. So I am giving. Where is the less pain?
Opioid.
Okay. So for pain management, I need opioids. Okay. Next.
Preventing gastric secretion.
Okay. I want less gastric reflux, less vomiting, less nausea. في عندنا intubation. We need the antacids. We need antiemetics. Yes, to prevent aspiration and gastric contact. More. Yes. So you want anticholinergics. First of all, we don't, because all general anesthesia will lead to this bradycardia. So we want anticholinergic to prevent the bradycardia, and we want to prevent the secretions in the lung. We don't want a lot of secretions going on in the lung because of the breathing and of the pathway. All antihistamines, again, to prevent allergic reactions, and antihistamines can be H1 or H2. H1 مثل ال PPI, proton pump inhibitors, that will inhibit gastric secretion, hyperacidity. Okay, strong drugs. Benzodiazepine is very needed for the anxiety, they use midazolam. Okay? Type. Let's look here. That's a nice picture, but it's not really, unfortunately, it's not clear. But it's what I said exactly, just to look at it from a different way. Okay? So this is the action of anesthesia adjunct drugs. Each one, okay. So a gastric acid secretion, H2 blockers, allergic reaction, antihistamines, aspiration of stomach contents. We give anti-emetoids, prevent bradycardia, anticholinergic, facilitate intubation, neuromuscular blocking agents. Okay?
Doctor,
So,
by adjunct drugs, we need
يعني نحن
combination of drugs.
هلا no احنا هون if I tell you that PPI is a general anesthesia, is it correct? It's not. It's an adjunct, something that I have to make this whole process work. I need adjunct drugs. Okay, I need the whole setup, or else I will suffer after the operation and during the operation. Clear? طيب. هلا, patient factors, drugs are chosen to provide safe and efficient anesthesia because we have to bear in mind we have certain patients disease قبل ما before the surgery. Ladies, but what do we do with them? So we have to be careful. So first of all, we have to look at the status of organ system. في عندنا cardiovascular system, okay? Anesthesia usually قلنا من قبل بيعملوا hypotension. This is, we have to keep it in mind. If someone has ischemia with hypertension, things are going to be really terrible. With vasoactive agents, مثلا epinephrine, phenylephrine, all of this to keep. يعني هون, by the way, يعني anesthesiologist is a very sensitive. So he needs to be شكله بدها تصير anesthesiologist. شو؟
Father's friend is in this.
So you agree with me. Okay. Respiratory system. What happens to the lungs during anesthesia? What happens to the lungs? The sense of CO2, of low levels of CO2 is diminished, by the way, during anesthesia. Although in general anesthesia بصير في bronchodilation, but the respiration is not efficient. Okay, that's why they do intubation, guys. That's why they do this artificial respiration for that patient, because they're not sure he's going to be able to pick it up and breathe normally. Okay, so asthma, for people who are asthmatic طبعا high risk abnormalities complicate control of inhalation anesthesia. Inhaled agents, يعني inhaled part of anesthetics اللي هن mainly structurally بيكونوا halogenated hydrocarbons. They depress respiration. Okay. Opioids. انتوا عارفين الاوبيويدز هدول painkiller, main adverse effect respiratory depression. Main. And I'm giving it for a patient who's asthmatic, for example, or a patient with complication with COPD, for example. Okay, so I have to be really careful. Liver and kidney. Liver and kidney, my main focus on these inhalational general anesthesia. Why? Because the structure is called halogenated part, bromium, fluorine. هذول كلهم can be toxic for the kidney and liver. Okay? So target organ for toxic effects, mainly halogenated anesthetics. طيب, pregnancy, pregnant woman. That's why نحن بنعطي for a pregnant woman usually, unless under control. But mainly نحن we are using this regional anesthesia to avoid systemic adverse effects and to affect the baby specifically. Okay, so in early pregnancy, if she's undergoing surgery, for example, in the first trimester, then fetal organogenesis is going to be affected. In other words, the growth of the different organs will be affected. If that patient is given nitrous oxide, which is the gas of the halogenated or the inhalational anesthetic, aplastic anemia can be seen. Benzodiazepine can lead to oral cleft in the third trimester. طيب, someone who is undergoing surgery but he's alcoholic, يعني he can't, 1 bottle a day and I can't do more. What's gonna affect someone who is on heavy alcohol intake if he goes under general anesthesia? Any help? أنا بزهق أقعد أحكي يعني بحب تحكوا عني حتى. شي مرة بدخلكم أنتوا تحضروا المحاضرة.
Cardiovascular problem.
هذا هن. Yeah, go ahead.
I think liver problem.
So liver function enzymes are going to be elevated for people on high alcohol intake. وبالتالي the metabolism of the anesthesia كمان will be elevated. Okay? What else? Opioids. Opioids will not have the effect of the anesthetic will not be as effective if someone is on opioids for a long time. Okay, the 3 stages of anesthesia. What are the 3 stages? I want to.
Induction.
And?
Maintenance.
And?
Recovery.
So, induction, usually قلنا, we prefer to induce with the IV propofol. Okay? So induction it's basically the period of time from the onset of administration of anesthetic to the development of effective surgical anesthesia. Usually propofol, 40 seconds done along other IV and inhalational drugs. I will not go through this combo because it's quite complicated. I'm just giving you basics. Maintenance, usually they maintain using halogenated anesthetics. والهالوجينيتد عندهم قصه انه الدوز response is very sharp. يعني any change بالدوز is going to be really very critical. So هنا we have to be very careful. Okay, it's a sustained surgical anesthesia. We need continuous monitoring of vital signs to balance the amount of drug inhaled with depth of anesthesia. Okay. طيب, the third thing is recovery. هي time from the discontinuation we stop. هلا how does he wake up? Basically redistribution. مش هي site of action البرين. Then if the level down in the blood, redistribution from the brain to the circulation. That's how he wakes up. Metabolism. It's basically we stopped, the blood levels go down, redistribution from the brain to the circulation takes care of the resuming or recovery from anesthesia. Okay. هلا, these are the examples of parenteral. شايفين البروبوفول. Thiopental is the older version of thiopental, and now because of the adverse effects, propofol is number 1. Okay, it's okay. Nitrous oxide is the only gas between the it's called halogenated hydrocarbons, except for the nitrous oxide. Type. Yes.
Can I ask something?
No.
What are halogenated drugs?
أيهم هالوثين وأيزوفلورين.
What are they? It contains bromide or
Halogen من halogen. So the structure of the general anesthesia is a long hydrocarbon with either bromide, fluorine.
group 17.
لا هيك كمان. لا هيك. أيوة. Fluorine, bromide. Chlorine. صح؟ طيب. This is the inhalational, including nitrous oxide volatile halogenated. Inhaled gases are they're volatile, by the way. They're volatile gases used primarily for maintenance of anesthesia after administration of IV agent. خلاص. We clear, right? Halogenated or nitrous oxide. Nitrous oxide usually not given alone, guys. More of an analgesic than anesthetic. Okay? مش لحاله. We can't give it alone. Okay. Again, depth of anesthesia can be rapidly altered by changing the inhaled concentration because they're very sharp. Dose restriction is very sharp. Changing of any of the concentrations will have immense effect. And there's no antagonist for these. يعني إذا في overdose done, we can't do much. Highly alert people should be there. Okay. طيب هلا basically اللي عم يعني هون I felt انه it's a bit complicated. I don't want to take you there. Just a general idea. Okay. How does it move? يعني نحن inhalational from lung to various body compartments. Okay. Basically they rely على something called solubility of blood. If something is very soluble in blood, the onset of action will be very slow. Okay. Why? Because it doesn't like to move somewhere else. From blood to other compartments, it's not going to be something easy because they're comfortable, they're soluble. It's like a loving environment for them. They don't want to move. So it depends on the solubility of blood and tissues and blood flow. So it depends how much the blood flow is there to move the anesthetic from the lungs to the tissues and on the solubility of the blood. The more soluble the blood, please keep it in mind, the more the onset will be delayed. It's not going to be rapid onset. Okay. Also, these agents, they decrease بصير في increased brain perfusion. They cause bronchodilation قلنا بس still the respiratory rate is okay, but also decrease spontaneous ventilation. Okay. طيب هلا زمان احنا last year حكينا بي او دي قلنا potency وطلعنا عينكم قلنا potency. هلا لما نحكي بجنرال anesthesia we're going to change the word potency. مش McDonald's لا no MAC. Okay, which is median effective dose. Median effective dose. The smaller the MAC, the more potent the drug. So minimum alveolar concentration of an inhalation anesthetic prevents the reaction to a standard surgical incision in 50% of subjects. This is definition of MAC. It's the minimum alveolar concentration of inhalation لأنه هذيك IV inhalation بس. That prevents the reaction to a stand يعني pain. That prevents me feeling pain in 50% of people, 50% of patients. It's a measure of potency of inhalation and anesthetics. More potent anesthetics have low MAC. خلاص? The lower the MAC, the higher the potency. Let me give you the list of drugs. So the more lipid soluble anesthetic, again, the smaller the MAC, صح? Higher potency. So the more, this is it. So halothane is the highest potency, lowest MAC. Nitrous oxide is really the highest MAC, lowest potency. Okay. You know what? I don't know if you're going to be overwhelmed by this. I'm going to move. قلنا قديش نسبة how much the amount of anesthetic dissolved in blood to the amount بالgas. The more the blood solubility or dissolving in blood, it is the onset of action is going to be less. Okay. Now let me move on. خلاص, talk about mechanism of action. If I'm giving a general anesthesia and I want to decrease the sensitivity to pain, what do you think is the mechanism of action for general anesthesia? تذكروا في عندنا في عندنا نيورو ترانسميتر ذات ار ستيمولاتوري انهبيتوري، وانا عم بحكي جنرال انستيزيا وانتم عارفين why we need general anesthesia. Come on, help me. Okay, so either I'm going to stimulate GABA or inhibit glutamate through what receptors? شو في عندنا بالجلوتامate؟ And what other things? So GABA, what about glycine? Inhibitory. So I want to خلاص سهلة؟ Easy. Yeah. Okay, so no specific receptor has been identified as the locus of general, because first of all, they're chemically unrelated. And that there's no single site. هلا بدنا نحكي لكم اللي published. Most of them, they increase the sensitivity to 2. Okay, so GABA A, most of them, they increase the sensitivity. يعني ممكن يكون more than one mechanism, but most of these drugs they increase the sensitivity to GABA, and they increase the activity of glycine receptors. Okay. What else? They block excitatory receptors. هلا الاكسبشن inhibiting NMDA, nitrous oxide وكيتامين. اوكي خلاص كابيش. نعم.
When you increase GABA,
right. When you increase hyperpolarized status, chloride channel بصير hyperpolarized, it's more challenging to do the action potential. يعني يعني بكون بدي امشي من هون لهون بس خلص. Yes, because the nerve, yes, the nerve needs to do action potential in order for me to sense the signal of pain. It's the only way is through sodium channel and action potential. That's why if you hyperpolarize a neuron, you are making it more difficult to reach the level of action potential. لا احنا فين والحب فين؟ احنا فين؟ الحب فين؟ عندنا نيورون وعندنا بلاد فيسل. نيورون ايش؟ اكشن بوتنشال. بلاد فيسل فاسدايل. احنا وين؟ بالسنترال نيرفس سيستم والبريفرال نيورون. ها؟ هلا في ديفرنت قلنا انه الايفكت for so many types of neurons بس اكيد البين is the main one لانه نحن we're suffering from pain, we don't want to be in pain. صح؟ اوكي اهلا وسهلا. طيب مين الاكزامبلز؟ GABA receptor potentiation, halogenated inhalational general anesthesia, barbiturates, benzodiazepines, propofol. Glycine receptor potentiation كمان. See, you don't see one drug, one mechanism. Could be more than one. Halogenated, so they can potentiate glycine receptors. Barbiturate. ايش الباربيتوريت؟ Yes, yes, yes. Okay. طيب glutamate is excitatory. خلاص وين نحن هلا؟ Let's give an example of halothane. Halothane was the anesthetic of choice in the past. في rapid induction with quick recovery. Okay, halothane. But there's a lot of adverse effects that were related with halothane, and so it was replaced by other drugs. Okay. الانالجيزيا ما هو please put in mind something very important. في anesthetic وفي analgesia. Some drugs can be more analgesic, less anesthetic property, with the opposite. This one is anesthetic, but analgesia wise is weak. That's why we add on opioids. We add on nitrous oxide. Nitrous oxide is the opposite. Nitrous oxide more analgesic, less anesthetic property. مش zero. في بس less. That's why in order to have a good anesthetic effect, we need to add on, for example, halogenated general anesthetic drugs. Okay, it's a potent bronchodilator and relax the skeletal and uterine muscles. What they do, basically severe bradycardia hypertension. This is the issue that made halothane not very popular. What is malignant hyperthermia? You've heard of it? Okay, so what we do basically, it is these twitching of the muscles. Okay, بصير في rapid body temperature increase بالbody temperature, tachycardia, muscle spasm. مشان هيك بنعطي dantrolene. Dantrolene بقلل الstiffness والtightness. بصير في serious arrhythmia. This is related with the halothane. That's why we don't really use it a lot. بيعمل severe hepatotoxicity and uterine atony and postpartum hemorrhage. يعني uterine ببطل يعمل contractility. فأكيد during delivery this is bad news. We don't do this. Okay, maybe if someone in the first trimester they're trying to stop her from losing the baby, maybe that could be used, but just to let you know. Okay, Another drug which has been replaced halothane, it's the little metabolism فما في toxicity على الليفر والكدني اللي هي الايزوفلورين. It does muscle relaxation and the adverse effects, again, less hypotension, it's dose dependent. يعني if I give low doses, hypotension is not going to be very high. Not used for, the issue with isoflurane, it's the smell. Smell is disgusting, it's pungent odor. But we don't use it for induction لأنه لسه alert نحن. But if we smell, it's going to be really irritating for us. It's not used for induction of general anesthesia, okay? When I tell you higher blood solubility, is that good or bad? So the onset of action was going to be delayed. So when I say it's higher blood solubility than this fluorane and sevoflurane, which is the other halogenated, then if I want a rapid onset, I will go for the second and third. Okay. The laughing gas. The laughing gas, it's good for kids. They try to give it for kids because they make them more relaxed. Isn't it used for when someone wisdom to بس بالإعدام مش بيعملوه بالإعدام بالأساسين what they give them laughing gas عشان to die laughing. I saw it in soap opera one time. I'm not sure. Okay. So it's a weak anesthetic, we said it, right? Frequently used at concentrations of 30 to 50%. They give it with oxygen. لأنه nitrous oxide sometimes, it's a gas, right? And it fills up the lungs. So you don't want the person to choke, right? It's taking the space of oxygen. So it has to be in combination with oxygen, okay? ما في respiratory depression, least hepatotoxic, ما في muscle relaxation, adjuvant. It's used as an adjuvant. Are we done? No. Last, I'm sure it's a very heavy lecture. Okay. Thiopental, the old part, the one that we don't use a lot, now we replace it with propofol. Okay. And we know the mechanism of propofol. We said GABA and glycine, propofol. But ketamine is NMDA antagonist. Ketamine, NMDA antagonist. Okay. So IV anesthetic بيعمل rapid induction. Anesthesia may then be maintained with an inhalation agent. Usually IV, we use it for inducing anesthesia. Okay, sometimes if we have a short surgery, we can use it alone. خلاص, sole agent for so short procedures. Thiopurate, barbiturate, basically in terms of mechanism, because the binding is on a GABA, but a different site than benzodiazepine. So again, it leads to hyperpolarization, more, yes, okay? But in details, you're going to take it with a lecture called anxiolytic hypnotics. Used for induction purposes, very quick, it's highly lipid soluble, and that's it. So that's the thiopental. The issue is it has severe CNS depression and hypotension. And people get urticaria, they get allergic because of histamine release. Propofol, propofol, you know why I put vial? Because doesn't dissolve easily. It's an emulsion, and it dissolves in soybean oil. Okay. It's in addition in its role as general anesthesia for induction of short onset, potent anti-emetic activity. طيب. Again, في عنا الناس اللي عندهم cardiac diseases, it has a very big cardiovascular depression. Ketamine, again, it is the one that is an NMDA agonist. Basically, ketamine is not used a lot because بسموها dissociative anesthesia. You know hallucinogens? Okay. So hallucinogens, some of them they work on NMDA receptors. So they can hallucination, stimulating that receptor has a lot of impact. So it's anesthesiac, but the patient appears to be awake and cannot sleep completely, but does not feel the pain. Okay, it provides sedation, amnesia, and immobility. We are done, and that's it. I made it. يلا. What would be the order of adjuncts to anesthesia administration? يعني, I'm not sure, because usually they start with the benzodiazepines because they want them to have the anxiety, and then the sequence I'm not sure of it. يعني, definitely they want them to yes, يعني, it's something so sophisticated as is quite a star of it, and it's midazolam. I will not ask you about it.
Specific drugs you have to know formulary.
انت دايما هيك بس بدك اكتئاب بس تشوفي الادويه، بس رح تبكي وحنعيط كلنا.
عشان هو ليس